Hi, this is Matthew Holt with another THCB Spotlight, and thrilled to have the team from Linus Health here, named after the Peanuts character, by the way, I've discovered. We're looking for the Charlie Brown's football officer. I have with me, left to right as you're looking at them, David Bates, who is the CEO, Chief Medical Officer, Alvaro Pascual Leone, who's in the middle, and Chief Product and Strategy Officer, John Showalter. Alvaro is a neurologist, and John is a primary care doc. David is just a PhD, so not that important. But what they're here to talk about and show me is Linus's role and ambitions as a testing diagnostic tool that's really trying to change how we are discovering and assessing people with neurological conditions, dementia, and the like. So they'll tell me much more about that. But why don't we start with Alvaro? Tell us what the hell is the problem? We know that dementia is a big issue and Alzheimer's is a big issue and the rest of it. But why is figuring, we know lots of people have got it and we don't have any cures. What's the problem that you guys are actually trying to fix?
Well, there are many problems with the way we approach it. To start with, contrary to what we hope, 92% of people with neurological disorders that cause cognitive problems are actually never diagnosed. So there's a large number of people who we fail to identify. Those who we do identify, we identify too late. There's many years of disease process before symptoms are recognized. And by that time, third problem, the kind of things we can do to actually alleviate the problems are not very effective. And so the situation right now is that brain-related disabilities are the #1 cause of disabilities worldwide, more than cancer, cardiovascular diseases together. And worst of all, that because of the way we approach it, the more money we throw at it, the more investment there is, the more disability we cause rather than the more health we promote. So we need a very different approach to brain health, sustaining it, identifying those who are at risk of losing it, enabling them to do the right thing, and tracking it. And that's the aspiration and goal of Linus Health, to have a real brain health care plan that includes early diagnosis and detection of problems to enable interventions, but that also empowers individuals to do the right thing with the help of their clinicians and sustain brain health.
So, John, you're a primary care doc. I assume a lot of this stuff shows up in the primary care doc world. There aren't enough, I understand, well, there aren't enough primary care docs, but there's probably not enough for sure neurologists and the specialists to figure this stuff out. So what's the current state of play? Primary care doc has a senior come into their office, things are getting a bit what happens next and now? What gets done now?
I mean, the current standard of care really is a referral to neurology, a primary care physician that is really engaged in brain health and cognitive impairment may do an assessment in their own clinic. It's likely to be a very short assessment, like a mini-cog, maybe possibly they're doing a MOCA, but more likely than not, there's a very short assessment that flags that there's a problem, and then there's a referral to neurology. And recent clinical trials have shown that over 70% of people deteriorate in the time it takes to get to neurology. So the state of play right now is really not benefiting primary care, neurology, and most importantly, not benefiting the patient. And there really is a lack of tools that allows primary care and primary care offices to step into a good diagnostic space around cognitive impairment.
All right. So, David, you presumably met these gents on the way somewhere, decided this was an issue. What's the, overall goal and idea behind what are you trying to build technologically at Linus Health, and where is it plugging into the healthcare system?
Yeah, Matthew, the overall goal is to help bring brain health into its rightful place in the global standard of care and make it accessible to everyone. And that's a lofty aspiration, but it's something we believe is achievable and absolutely necessary. what we have built is a suite, an end-to-end platform that really is like a turnkey software-based solution for setting up a cognitive and brain health service line in a health system. You ask a lot of healthcare systems, some executives, what is your brain health strategy for 2025? And many, will admit we need one, but we don't have one. And that is because to date, there's not really a service line for cognitive care. It's just as Alvaro and John alluded to, it's really they show up, complaints, maybe do an assessment, maybe not, refer them to neurology, and whatever options are available from there. But we intend to change that. And some of the fundamental principles of our capability and what makes us unique is, the premise that behavior is the primary observable output of the brain. And if we can use sensors and advanced algorithms to assess behavior, especially a prescribed behavior at present, you can effectively understand what's going on in the brain, and you can scale certain time-intensive and tedious aspects of a specialist like Alvaro using the technology. And so you can get a clinical impression on that individual in a very short period of time and give primary care doctors like John insights into what's going on with the brain, what's my next step, how do I work them up, check for depression, check meds, do an anticholinergic burden calculation, sleep apnea, so on and so forth, what to order. And then when Alvaro gets it, he has a full package workup. He can review it. He can replay the assessment. He can hear it. He can send out additional assessments if he wants to. He can, in coordination with John, generate a care plan and a monitoring plan that's personalized to the individual so that they can carry out an action plan by themselves or together with a care partner to optimize their quality of life and indeed their prognosis, and preserve independence as much as possible. And as John said, especially at the MCI state, early MCI, stabilize that.
Sorry, what's MCI?
Mild cognitive impairment.
Okay.
Great question.
I clearly have that because I don't. But keep
Well,
going.
at the mild cognitive impairment, it's not yet affecting their daily life. They can still have a good quality of life, but they need to be managed in a way that preserves that quality of life, and they don't progress, hopefully, to dementia.
Right. So before we dive into, and you're going to show me how this works and how it fits into the workflow, but the very precise question, maybe not for you, maybe for Alvaro, is you got that the fear about people, dementia is that, or cognitive impairment of any kind is you go, well, it's happening to me, but what the hell can I do about it? And I know there are people selling supplements online and telling you testosterone or whatever. But is there stuff we can actually do to delay or ameliorate mild impairment?
Yes, that's a great question. So there's many things we can do. To start with, we can prepare ourselves, which is no small thing. It actually is one of the things that people say would be most valuable to them if there was a test that they could do that anticipates whether they're going to have problems on the road. They would live differently, and that alone would be of value. But even without that, or even ahead of that, we can actually prescribe personalized interventions that actually make a difference. And they start with lifestyle modifications that together can reduce the risk of potential progression towards dementia by 40 to 80%. That makes a huge difference, but it doesn't work if you start too late.
Right.
So part of the challenge is to maintain your brain health, to prevent the problems to begin with. And on top of it, we now have medications. We have medications that actually for specific diseases go at the root of the pathology and clean up, reduce the burden of that pathology, and make a big difference in terms of the risk of disease progression.
So there is something you can do. So it's worth figuring out what it is. And I assume that if you get it early and you can prevent it, down the road, you're potentially saving a lot of not only pain and suffering, but money, right?
That's exactly right. I mean, we're in a very similar place than we were with diabetes or with many forms of cancer some decades ago. where we came to realize that if you identify the problem early and you intervene early, which means if you don't wait for the specialist in all instances, but actually empower primary care providers to do the right thing with the patients ahead of time before complications develop, that you can actually prevent the complications. And that's what we need to do with brain health, prevent the complications and disabilities that come from diseases that may lead to dementia or may lead to substantial impairment.
And what age should people start taking this test in general? If you're going to put it in all PCP's sort of general workflow.
Yeah, I think at this point, probably in the 50s. I think ultimately, hopefully earlier than that. But I think
but early enough along in life that people shouldn't be, you should be starting to pick stuff up. And then does that answer vary if it's a presidential candidate or a current president? Don't answer that question.
I'm sorry.
Don't answer that one. All right. So let's take a look and see what the actual test looks like. Okay, so you're going to show me what the actual experience looks like. And I think you, as a primary care doc, John, are sending an email. So what happens next?
Yeah, so I chose an assessment for David to do before he came in for his visit. He got an email. He clicks on start assessment, and then it launches him directly into his assessment.
All right. Assessment start.
We go ahead and can send him, and then we test the system.
I can hear it. Hello. Hear it? Hello. All right.
I would like you to pretend that you are going shopping. I am going to read a list of things you need to buy. When I am finished reading the whole list, I will ask you to say the words back to me in any order. Press the start button when you are ready to begin. The words are pineapple, drill, stapler, cantaloupe, eraser, pliers. Please say the words back to me now in any order.
Pineapple, drill, stapler, cantaloupe, pliers, eraser.
Now I am going to read the shopping list again. When I am finished reading the whole list, I will ask you to say the words back to me in any order. Press the start button when you are ready to begin. The words are pineapple, drill, stapler, cantaloupe, eraser, pliers. Please say the words back to me now in any order.
Pineapple, drill, stapler, cantaloupe, eraser, pineapple, pliers.
In this task, you will be shown a category. Then you will name as many items in the category. For example, if the category is flowers, you might say rose, tulip. You will have 1 minute to name as many items from the category as you can. Remember to say them out loud. Press start when you are ready to begin.
Monkey, giraffe, lion, rhinoceros, crocodile, alligator, caiman, iguana, parrot, toucan, eagle, bear, wolf, coyote, orangutan, rattlesnake, boa constrictor, python, shark, orca, barracuda, trout, sea bass. antelope, deer, moose, grizzly, ram, cat, dog, goldfish, penguin, turtle.
Your 1 minute is up. You have completed this task. Now you will hear 5 numbers. After listening to all of them, repeat the numbers backwards. If you hear 1, 4, 2, 7, 5, you would say 5, 7, 2, 4, 1. Let's begin with the practice. 2, 8, 4, 9, 6,
6, 9, 4, 8, 2.
If you said 6, 9, 4, 8, 2, you are correct. You will do this 3 times. You can retry the practice or tap start to begin. 8, 2, 3, 1, 6.
6, 1, 3, 2, 8.
Four, 8, 7, 9, 1.
1, 9, 7, 8, 4.
Two, 5, 4, 6, 9.
9, 6, 5, 4, 2.
Please say the words from the shopping list in any order.
Pineapple, wrench, eraser, cantaloupe, drill, stapler.
Now you will see groups of 3 words. For each group, please choose which word was on the shopping list. Press the start button when you are ready to begin. Which word was on the shopping list? Peaches, pineapple, oranges. Which word was on the shopping list? Hammer, nails, drill. Which word was on the shopping list? Stapler, pencil, envelopes. Which word was on the shopping list? Strawberries, apple, cantaloupe. Which word was on the shopping list? Paper, eraser, stamps. Which word was on the shopping list? Pliers, wrench, screwdriver.
That's the end of the test, and then they're able to provide feedback if they had any difficulties or struggles.
So that's great. So that's, I guess, Alvaro, there's like a particular part of the assessment that looks at sort of verbal recall is what you're trying to do here. I don't know. I think, John, you did that far too well. you're not as dumb as the rest of us because I can remember any of the shopping list by the time they got back to it. Either that or you've been practicing for this test, which you shouldn't really be doing. But Alvaro, I mean, before we go to look at the answers, what's going on there in terms of, is there a specific part of, early onset dementia or what have you that does verbal stuff compared to visual? Because there was some visual stuff later in the test. And I know there are a bunch of other companies that have done, maybe you're doing this as well, have done visual type tests where you have to draw a squiggly line or, or move something into a house, move some stuff around. So what else do you have? What else did you not show us? So.
Yeah, it's a great question. So there are over 30 different assessments that we can do, and they capture different aspects of the brain function. This one is particularly suited for remote assessment, as John was saying, because you send it to somebody and you can capture the performance in addition to capturing by voice metrics a number of different aspects that have to do with mood, with
Oh, are you assessing the voice biometrics as well as part of this? Okay,
yeah,
cool. Very interesting.
So we're one of the things that we do that is different from other companies is that we measure not just the outcome of the task, but the process by which you go about doing it, and that's called process evaluation or Boston process method, and because it was started here, and what technology does is capture the way, in this case, David was going about doing the task, and we could do the same if it was a drawing task.
So if he was slowing, or he was sort of stuttering, or he was struggling to get the words out but got them right, it would change the score compared to like the rather clever way he did it.
That's right. So quite different to say, was pliers part of the list, or if you say pliers, for example.
So it automatically picks that kind of stuff up.
Yeah, it does. And so there's hesitations, there's latencies, there are pauses, there are timings, there are voice and language metrics. The second thing to your question is that these are tasks that are very well known, very well established in cognitive neuroscience and neuropsychology, and they tap different cognitive functions, different domains. In order to think of animals, for example, you need to tap into different subcategories, and you could see that in David, right? He was getting rolling with deer and moose, and then sort of shifted to fish and did a few, and then shifted to house pet and did a few, and we can measure not just how many animals you come up with, but also how closely or far away from a semantic point of view these different elements, these different animals' names are to each other. And so we can get a lot of insight into the function of the brain by looking at great detail into the cognitive processes involved. The tasks that he did fundamentally tap into encoding and retrieval of memory. That was the first one. It's something called the Philadelphia Verbal Learning Task, and has been very well established. And we can tap on how quickly his brain is learning a new list and how well it retrieves it immediately, and also how well it retrieves it after a delay, and whether or not he recognizes the items. And that taps very specifically on memory systems, and those are the first ones oftentimes affected in illnesses like Alzheimer's disease. So a very sensitive measure of it. Then the verbal fluency is a very sensitive measure of more frontal systems, but because of the semantic nature, it's the interaction between frontal and temporal areas, very specific temporal areas in the brain, and can help sort out things like Alzheimer's disease as differential diagnosis from frontal dementias or frontotemporal dementias. And in somebody young, like David, that's what John was thinking about. It's like, let me make sure that I differentiate these potential neurodegenerative diseases. And then the digit span, the repeating of the numbers, will assess attention, but also will assess executive function, the ability to keep track of things in a proper order, to retrieve them, to put them backwards in order and give them back. And that's a very sensitive measure for frontal systems that might be affected in many things, including depression and anxiety disorders, but also little strokes or illnesses like dementia producing degenerative diseases. So it's a very quick but very comprehensive assessment of the brain state.
So a couple of quick follow-up questions for you and for John, or probably for John. So, how often is it, you mentioned, I think, that 92% of people never get diagnosed. How often are people now getting this type of assessment in their day-to-day or general, if everyone over 50 should get it, I mean, I've never had one from other than the one that that David gave me in a bar, which, but seriously, I mean, I don't know how often these should be prescribed as, like your colon test or whatever the hell your colonoscopy you should be getting at age 55, whatever it is. So number one, how often is it happening? And B, has that been a problem that you couldn't scale them because these were done on paper? And now if we have this type of tool, we can scale them much more often. And then the second question is, what do I see as what does John or the neurologist, what does who get back on the professional clinical side?
Yeah, so to answer your first question, the status quo is that this testing is not getting done. We might be doing a mini cog, but that is not nearly as sensitive as something like the test that we just did.
And only about 20% or so of primary care providers are actually using tests, right? And they know they should, but they are not using them.
Presumably because they have to do it in their office, or they have to somebody in the office do it on paper, and it's a pain in the ass, right? You have to somebody to repeat the words, and it's just not done automatically.
Yeah, so this takes staff time. The administration of a test like this is typically done by a psychometrician, a neurologist, or a neuropsychologist. The Linus clinical suite skills up the entire primary care staff to be able to administer these, which is one of the key features of the system. And what we're looking at now is what the primary care physician sees. So as Alvaro said, there's all kinds of really deep analysis that neurologists do on this, that neuropsychologists do on this. Really what primary care is looking for is, how do they compare to their peers? Are they red, yellow, green? So we take the immediate recall. David did great. He got 6 out of 6 the first time, 5 out of 6 the next time. And then we moved him on to that semantic fluency. He named 32 words. Again, this was all scored in the background in the cloud. It's presented to me as a primary care doc as a score of 32. And then also back to some of that process measures. How did he do in each 15-second block? Did he stay pretty stable?
This is when he ran out of animals to talk about.
So we ran out of it. So running out above 32 is great. In this particular case, the score wasn't adjusted for the education level because we don't have all the details in this fake patient. But we end up with percentiles. This would be well in the 90th percentile. Moved on to the backward digit span. This performance was in the top quartile. David did miss 2 of putting them in the right order, which is perfectly normal. These again are very challenging tests, and we're looking for evidence of impairment. But back to that process, he did name all 15 numbers, but got two of them out of order. And with all of the voice and speech, you can go back and listen to what was actually done. You can see how long it took him to complete those. And then, as Alvaro said, we get into the delayed recall, and 93rd percentile remembered 5 out of 6. But then when he went to the delayed recognition, actually got 6 out of 6. So it's slightly easier with that prompting to pick off the list of 3. And you can really see in patients a difference between when they do poorly on the delayed recall unprompted and then recover back up to 6 out of 6, and can give you some additional indication of, is this more executive memory, mixed. But from a primary care standpoint, I can quickly come through and look at these. I can go through and see, which they picked off the list to understand where the confusion was. And very excitingly, in the if we had done this next week, we actually would have also included our new summary report. So the new thing we're introducing is our summary report that's based around cognitive domains and really providing advanced insights for the primary care physicians to understand, based upon those tests that we just took that Alvaro was talking about, how is their executive function, how is their their planning part of the brain, how is their language, how well are they able to speak and process words, what is their memory and learning, that classic Alzheimer's disease profile and symptom, and then again that complex attention and understanding the amount of effort and work that it takes to pay attention to these 7 minutes, and understanding which area of the brain is a problem can really accelerate the referral, really accelerate the diagnosis, and bring an understanding of, do I need to dig into depression, or could this be somebody with undiagnosed ADHD that has an attention problem that's driving the other testing. But this type of cognitive domain analysis typically requires referrals, typically requires 6 to 9 months to get. And we're going to be able to bring it to the primary care physicians almost in real time. So, in less than 60 seconds of processing, this will be available inside the EHR for primary care physicians to take action against.
So that's
goal is,
go ahead, Alvaro.
sorry if I may, the goal is to optimize the care for the patient and the resources, right? It's not about not getting the patients to the neurologist, but it's actually getting those patients to the neurologist that really need me now, and not book up my time with patients who have actions that can be taken by a primary care provider to effectively address the problems. So
can we talk about that process just a little bit? So you come in, I see this person has got some bad scores. This is not the summary of what David just did, because he's got a PhD from some fancy university and isn't old and dumb yet like me. But this is a mock-up of somebody who has got problems and needs referrals, right? So I see this as a primary care doctor. I'm using your system. What do I do next? Let's say, is there a thing saying, flashing red light, you might want to refer this person, and here's who you refer it to? What's the sort of next part of the workflow to get them to Alvaro in his clinic?
Yeah, so very excitingly, and one of the things that we've been waiting on to bring this forward is the clinical decision support that underlines these cognitive domains and what to do with different patterns of cognitive domain impairment, because it's really important to get the right people fast track to neurology. But if, again, leaning on complex attention, if complex attention was a driver, I really need to look at sleep problems, sleep apnea, depression, untreated ADHD, all of which doesn't need to go to Alvaro. If it's identified that there's depression, let's treat the depression and retest. If you took this and you were not on your ADHD medication, let's get you on your ADHD medication to retest. Let's not just knee-jerk send you to neurology, but there's a cognitive domain-based clinical decision support that goes along with this, that Alvaro and our medical team here have done an awesome job on.
And I think we just to emphasize the importance of that, we have not just generated it, but vetted it with experts that have reviewed it and agreed, and applied and obtained approval at the European community for those decision supports, which are regulated in Europe in a different way than here, actually stricter. So that, to your point, Matthew, what we want to offer clinicians are actionable recommendations that don't leave them wondering what the heck does this score mean, but rather unpacks it in explicit suggestions of consider. We don't dictate what they do, but we remind them of things that they could test for, that they may want to consider asking for additional testing before just referring the patient or guiding in their decision.
Okay, so that's great. You've got the things that you keep it on board. You got the people you refer out. So let's flip over to the sort of the business end of this, and maybe I'll ask you, David. So there've been a bunch of people who've done neurological testing, and there's been people who've gone, have raised money and then gone out of business and what have you. There's sort of a bit of a history here. Why is it kind of the right time? It makes a lot of sense, right? It makes all the sense in the world, for the reasons you said. As Alvaro discussed earlier in the conversation, there are things you can do. I suspect the thing you should do is better diet and more exercise, because that's the same thing you do for everything. Right? It's the same as diabetes or whatever. But whatever the thing you do, or play Sudoku or whatever the answer is. How and yes, we have a lot of elderly people. We don't have enough neurologists. Obviously, this should become something that gets done. But how are you going to get this into the hands of primary care docs? Where's that demand, coming from? Or how do you stimulate that demand or educate them about that demand? How do you get systems to sort of make this something that should happen? Because obviously, it's kind of been tried before and it hasn't really made it. So how do you get there when some of the others who've been, doing this before you have, maybe they did it wrong, maybe it was the wrong timing, maybe it was just, luck or whatever. But how do you get this to work?
Yeah, I mean that's the real question. So I think that those who've gone before us, they probably were ahead of the market, because in a lot of physicians' consideration, there's nothing they can do about cognitive issues, and so it wasn't sought after because it's just tell people they got a problem and there's no solution offered. That all, as we know, is changing, and it's changing rapidly. Both the emergence of new therapies, such as the disease-modifying therapies from Eisai and Lilly, and soon to come from others, as well as non-invasive interventions like TMS or current stimulation or neuromodulation, and also we're all hopeful that the GLP-1s will show benefit at preventing dementia. And lastly, and has been shown empirically, is a lifestyle modification and proactive management of chronic illnesses can prevent progression to dementia for many of those suffering with mild cognitive impairment. And so now that there's a cadre of treatment options and there's advancements in detection options, the timing is now, especially with an aging population. The business model's all worked out. So it's really, those health systems, and we're partnering with many who are proactive in, hey, the brain is super important to this population. Actually, the control center of the human is really where health arises from, and a healthy brain is a healthy person. And so, we're really hopeful that more and more systems put this at the top of their list. It's in Alzheimer's, dementia is in the top 5 major causes, but it affects both people with hypertension and diabetes. They're at very high risk, and the worst hypertensive or diabetic patient is an undiagnosed hypertensive or diabetic patient, because they don't remember their meds, they don't remember their care, and they're the hardest ones, the most costly ones. They're the ones that end up in the ER. And having knowledge about their brain health and a service line to manage them is the way to really promote health and to reduce costs of care, and to accurately understand, especially those under value-based care, what is the risk of your population? Are you coding accurately those folks, and are you managing them and offering them the right services to care for their condition and prevent advancement of the illness as much as possible?
So let me point you a bit about that. You said the business model is ready for now, back and forth. What when you go to either a health system or an insurer or what have you, what are they saying? This is a good idea, and yes, it may prevent people getting dementia down the road or improve worsening their hypertension or whatever. Are they actually in with you? How close? A lot of people go and say I was talking to a pediatric company the other day, just on my on my blog last week, and they were, they're explaining how their wraparound pediatrics thing saves ER visits, from kids who get their feeding tube messed up in the middle of the night. And I get that. This is a little bit down the path, right? Are you trying to tell me that you're going to save the money? Are they able to bill for this in a way they couldn't before? What's the thing that is switching them on and saying, yes, we will work with you here? Whereas, as I said, some of your competitor/predecessor companies in this space have had trouble getting it adopted.
Yeah, so it's actually all of the above. I mean, the fee for service model is pretty straightforward. CMS does have a billing pathway that begins with the assessment to the kind of evaluation of the results of that assessment and communication with the patient, all the way to the cognitive assessment and care planning for people who have diagnosed cognitive issues. And there's a very clear billing pathway there, as well as on the downstream revenues. So filling those MRI machines, the specialist services, the blood panels, the pharmacy at the hospital, especially with these infusions and other medications. So there's an economic pathway there that has a strong ROI, as well as, on the value-based side, you're bearing the risk of this population. Your diagnosed incidence is probably a fraction of what your true incidence is. And you don't know who they are, but they're showing up in the ER. They're not taking their medication. Their cost is going up. And if you would just identify them, you would be accurately coding your risk adjustment factors. And also, a study came out of Ochsner that showed, just by managing their dementia, you're saving $475 per member per month. So there is, on the revenue side, accurate RAF is important because you are bearing that risk. And on the management side, it is massive cost reduction for handling those patients. And importantly, satisfaction, patient satisfaction, caregiver satisfaction, when they are being engaged around their brain health and provided access to services to promote their own brain health and to get the education and to be able to have that quality of life, they are satisfied. They are seeking that information. And so your quality scores go up. So you're reducing readmissions, you're reducing all these things in management, you're getting compensated for the risk you're bearing. And most importantly, you are affecting for the better the lives of your members, of the patients you're serving. And that's really the proposition. And from there, their diabetes is better managed, their hypertension is better managed. You go on COPD, chronic heart failure.
I get the flavor.
Yeah.
So let me ask you so you can walk into the fee-for-service land and say, hey, this is great. And by the way, we're going to bump up, a bunch of the stuff that you're doing and make you get, your neurologists need to be fuller with with patients who really need them or what have you. And by the way, you might sell some more MRIs and whatever. And you can go to the value-based care, at-risk folks and say, we're going to save you some money down the line. How's it working? Who's picking it up the fastest? And tell me where you are as a company now with hospital systems, health plans. Give me a sense of the flavor.
Yeah, so we are servicing, we're partnering with a number of academic medical center health system and community health systems, large care delivery organizations, as well as, many, hundreds of physician practices and neurology clinics, as well as concierge clinics, and we're actually in Europe serving some of their private hospital systems. We're in the UK. So it's who either they have a senior population or they have taken a proactive stance on brain health because they know it resonates with the population. V28, which is the new, issuance of Medicare, it is gearing more towards brain health services and reducing a little bit towards, the hypertension, the diabetes, but increasing on the brain health side. So the winds of change are here, and they're all in favor, I would say, of brain health. And I think those who are proactive in, really this is the number one concern for patients over 55, for people over 55, that they would get dementia. The surveys have all showed it's Everyone wants information. They all want to know what's going on. 90-something%. They want to know about their brain health, what they can do, how they can avoid dementia. They want to be engaged by their primary care concerning their brain health. And they want to find solutions. They want to find education. And the systems that are on the move are the ones that are going to be focusing on brain health in the coming years. Even at Davos this year, just last in January, they said this is a priority. Brain health is a priority worldwide. It matters so much, of course, to prevent illness, but also productivity in society, cost to society. It's either a net gain in goods and services to people with good brain health, or it's a detraction because they're suffering.
Sure. So let me push you a bit. How many systems are you in today, and how many do you think you're going to be in, or in call it 2 years? I mean, how is this uptake? You're talking a good game. How is the uptake actually happening, and how many patients are you touching now, and how many are you going to be touching shortly?
Yeah, so probably what, a dozen health systems, and like I said, couple 150 maybe clinical practices.
I think we just crossed 200.
200 clinical practices, hundreds of doctors, obviously, maybe thousands across that, and patients. I think tens and tens of thousands. We can actually look at across the country. Maybe it's more than that. And then you said, how many do you hope at the end of this year? I hope we have, dozens and dozens, approaching 100 health systems, and hundreds of thousands of patients. I want to get to millions next year. I mean,
Yeah, but you have whatever it is, 100 million people over 55 in this country alone. So you should, big target to go for. That's great. All right, real quick on the company. You've been around how many years? And you raised a decent chunk of money, but a while back. Just give me some of the metrics of the company, of how long you've been around, how many people, how much you raised, how many people you got, and where you are in that kind of startup cycle.
Yeah, I mean, we've been around for 5.5 years. The first 3.5 years were spent developing the platform, working with pharma partners, and serving research. So we're running lots of clinical trials, lots of research studies, building out the platform. We went into our first clinics in late 2023. And then we went into our first health systems in early 2024. And we've really just been working with them to perfect the enterprise offering. And now we're scaling that up, moving into the payviders, moving into serving payers, because we have, we can engage consumers through their applications. So that's where we are from a commercialization. We continue to work with lots of the leading pharma companies on their clinical trials. We are working with...
That's the show to see if the drugs are screwing people up cognitively as they go in through clinical trials, right? Essentially.
I think they appreciate the ease of administration, the low participant burden, and the accuracy of the assessment. And so they see thousands of metrics, and they get a much greater objective picture into what's going on with the brain function and the response to therapy.
But you're assuming that I'm assuming from this conversation you think that the general care pattern of primary care and health systems are going to be the main venue for
that's going to be the main venue, as well as outside of the clinic engagement connected to the clinic.
Right.
So the doctor is always in the loop, but because of the constraints of time, being able to engage outside the clinic, being able to engage in the clinic, and then go with the patient, bringing back the monitoring and progress, how they're doing, being able to readjust plans, meds, whatever's necessary to optimize brain health outcomes. So that's on that side. We did our Series B round of funding in 2021. We do expect to do our Series C this year, and looking to really use that raise to accelerate growth and our ability to serve the population. We have a super exciting roadmap, as you can imagine, with all the advances in AI And with our digital platform, you need digital in order to do advanced AI. And so we're well positioned to help health systems and payers and such organizations really take advantage of the innovations coming forth and serving patients with better healthcare more efficiently at scale and with equity, so everyone can access them. And I think that's really the power of these innovations in technologies that we're bringing to market.
Yeah, well said. So I think we'll wrap it there. We've had a good long look into both the business of Linus Health, but also how the technology actually works, which is, I think, super exciting. And yeah, this is one of those things where it'll probably be like getting your cholesterol checked every year or whatever. You wonder why you didn't do it before, and it probably wasn't medical standard of practice, and now it should be. And with, as you said, the impact of all this stuff, the fact we can do something about it, and the fact that it's a relative. I won't ask you about pricing, but a relatively cheap initial test that can be scaled because of the technology we have. It's probably one of the things to be done. I look forward to seeing you guys go to the mat and get those millions of people on the system as soon as we can. All right. Okay. I've been talking with John Showalter, who's the Chief Product Officer, Alvaro Pascual Leone, who is the Chief Medical Officer, and David Bates, the CEO, who's somehow disappeared off the camera. I don't know how this works. The fucking camera you guys have. You have to say something. Someone disappeared at Linus Health. Gents, thanks for your time. Really interesting to catch up with you and see what you are doing. Thanks for your time today.
Thanks so much,
Thank
Matthew.
you so much.
Thank you.